Good morning, good afternoon, good evening. My name is Jeff Lazarus, and I'm delighted to welcome you to our webinar, Innovations in Nafld Care. I'm joined by my co-chair, Jörn Schattenberg. Dr. Schattenberg is a professor of medicine at the University Medical Center Mainz in Germany. He's a clinical physician and hepatology consultant at the University Medical Center, also in Mainz, and he's well known from his leadership in multiple clinical trials and his involvement in the EPOS program and the LITMIS consortium.
Well, thank you, Jeff, for leading in, and it's my pleasure to reach out and welcome you too. I think you have one or two more slides before we head into the first session.
Thank you. Yes, well, we are delighted that so many people were able to join us today, or in this case in Spain, tonight. This is the Innovations in Nafld Care webinar. So we have two sessions in lieu of meeting in person. This will be a virtual event. We have 5 invited lectures from 4 countries. Over 300 have registered. Welcome to everyone. And you are from over 80 countries. Next. Our objectives with this meeting are really to highlight the burden that liver disease poses on healthcare systems, and importantly, to gather patients and leading experts from different disciplines involved in Nafld care. We think this sets this meeting apart from so many others, and that we're able to bring together a multidisciplinary group of speakers as well as participants. And finally, we seek to share knowledge that exists in different fields and support the implementation of a multidisciplinary approach using comprehensive models of care for Nafld and NASH. Now over to you, Jörn.
Thank you, Jeff. And again, thank you for everyone who's following online. I think this is the kickoff to a very exciting set, or at least an event later this year. And we're really trying to make some progress here in terms of all the progress that has been made in terms of diagnostics and therapeutics. So I'm very excited to see this kick off. And without further ado, I'll be very honored to introduce the chairs of the first session. The first chair is Professor Lena Allen. She is the director of the Nafld program at the Mayo Clinic in Rochester and a professor of medicine there. Hi and welcome, Alina.
Hello, thank you for having me.
Yes, of course. And then my co-chair and who's known to everybody in the field, Professor Jeff Lazarus, who's a professor at the Global Health Institute in Barcelona, and also the co-chair of the EASL International Liver Foundation, has done seminal work in terms of defining novel models and raising awareness. I'm very glad to have you here and lead this off. Jeff, the floor is yours.
Thank you. And thank you very much to everyone who has supported the webinar, both our financial support as well as the many endorsers that were just shown on the slides. So our first speaker in this first session is Dr. Sven Frank, who's known for conducting clinical research at his unit and is a partner in several research consortia supported by the European Commission and by the Innovative Medicines Initiative, with a focus on NASH pathophysiology, biomarker research, and hepatocellular carcinoma. Professor Frank is a scientific committee member involved in the design of several phase 2 and current phase 3 trials in Nafld, and is national and international lead PI of several of these trials. And I worked recently with Dr. Frank and many others on the first Nafld patient guidance published and presented in the autumn. Dr. Frank will be speaking on this Nafld guidance. Why is it needed, and why did it take so long to get such guidance? Over to you, Dr. Frank.
Thank you. Thank you for the kind introduction and for the invitation to be with you. I have been given a very long title about the Nafld patient guidelines, so let's get started straight away. Now, why Nafld patient guidelines? Why patient guidelines? We have very few examples of patient guidelines in the liver space. The most important example is the one from the PBC Foundation, so from patients living with primary biliary cholangitis. And what you can find in the first paragraph of that document is that they clearly state, okay, you have the guideline by the Scientific Society, which is there to help clinicians for the diagnosis and the management of their patients. But the PBC Foundation felt that it was crucial that also patients were aware of that guidelines, the content of that guidelines, and how these guidelines could be useful to optimize their management. So it's mainly about what was said also in the title of the document, a kind of lay translation starting from the guideline by the Scientific Society. We did it a little bit differently for the Nafld patient guideline, as you will see. Now, why patient guidelines? Well, there are 4 main reasons for it. First of all, it's about empowerment. Empowerment is, of course, important for every patient in every disease, but in particular for this disease, so closely correlated to lifestyle, and in which lifestyle changes are so important for the management, that empowerment of patients is crucial. Another aspect is advocacy. There is almost no specific policy, healthcare policy around Nafld, and it's urgently needed. There's a problem of awareness. There's a lack of awareness amongst healthcare providers, first line, second line, third line, but also amongst policymakers and in society, and also especially in patients at risks. And finally, there's a need for harmonization. There's a lot of information out there, but it's sometimes discordant. It's not always backed by science. So there's really need for harmonized information about the disease. So that's why we produced in the end the Nafld guideline. You can see the front page here. It was published in September last year. What is important, and I have copy-pasted here the first paragraph of the document, is the purpose of this guideline. First of all, of course, it starts from the consideration that Nafld is a serious condition, and that it's important for you as a patient to develop a full understanding of this serious condition. And why is that important, and why can that guideline be helpful? Well, first of all, if you have a good understanding of the condition, you can play an active role in your own healthcare management. Second, you will better understand everything that is discussed with you by the healthcare providers. And finally, it will also enable you to monitor yourself the evolution of your condition and the result of the management that is implemented. Now, it was a long journey. We started in April 2019 at the International Liver Congress with, first of all, launching the idea. And then the first step was, of course, to compose the writing group. And the basic idea was that we needed a multidisciplinary and multi-stakeholder group. And the list of authors is here for you, but that's not the important thing. The important thing is that you see here physicians, hepatologists, endocrinologists, physicians specialized in the treatment of obesity, but also people that are experienced in nutrition, in physical activity, and also patients and patient representatives. And what is also important is that when this writing group came up with the draft of the document, that document was sent to several patients groups outside the writing group to have their comments and input. People from the coalition living with obesity, of people living with obesity in Europe, German patients, Italian patients, and so on. So really the guideline has been developed by patients, patient representatives, clinicians, and scientists. The approach was also a little bit different because we had, of course, the science of the scientific document, but we started in another way. We really started by thinking what should be in that document, what should be the content, what are the topics to discuss. So we made a kind of outline of the document and the chapters, and then we allocated chapters to smaller writing groups. And these smaller writing groups then came up with a document for their chapter that was then compiled in one document. And that first single document was only produced in November 2020, which means about a year and a half after the idea was launched. Why? Because we needed really to go through different rounds of discussion, also several meetings online to discuss issues that still needed some discussion to find a consensus. That was so for the smaller chapters, but that was also for the whole document and also for the list of illustrations that we developed in parallel. And once we then came up with the final document where the whole writing group agreed upon, it was, as I said, sent to several groups of patients outside the group that composed the document to have their input, their comments, their recommendations. These were then integrated. Again, the document was sent through several rounds to the group to have everybody's approval and to discuss final points. And then, of course, it was sent to a professional writer and designer to have the final document that, as I said, was published in September 2021 and is available online for you to read. Here you see just a few pages out of that document just to illustrate you how it looks like, and also to tell you that it's a very large document containing a lot of information. Now, what is still important is it's a guideline. So it's something that should support you in making informed decisions, but it's not there to replace your individual consultation with the people that help you with your medical management, so your medical care team. As I said, it's a very large document. We are now working on a short version. You see here a draft of the front page, 14 important points for people at risk for or living with Nafld. These cover the different chapters and then refer to the large document for more information, but it's more easily accessible and readable. And we also hope that this will be translated into different languages. For the whole document, that's probably a little bit difficult, but for this short version, this should be perfectly feasible. So with this, I would like to thank once again all the people that have contributed to this document. I would like to thank you for your attention and happy to take your questions.
Thank you, Professor Frank, for the wonderful presentation. It is my honor to introduce our next speaker, Dr. Kenneth Cousy. He is a professor of medicine and the chief of the Division of Endocrinology and Diabetes and Metabolism at the University of Florida at Gainesville and at the Veterans Administration Medical Center in Gainesville, Florida. He is internationally recognized for his work at the intersection between non-alcoholic fatty liver disease and diabetes, and his work is mainly focused on underlying mechanisms and new treatments for Nafld and NASH. Today, he will speak about why endocrinologists do not screen for Nafld as a complication of type 2 diabetes. Dr. Cousy.
Good morning. I would like to thank the organizers for having me. I'm Dr. Kenneth Cousy from the University of Florida, and I'm being asked in the next 10 minutes to explain to you why don't endocrinologists screen for non-alcoholic fatty liver disease as a complication of type 2 diabetes. So it's not a simple issue, but we'll try to cover it briefly and promote some discussion afterwards. These are my disclosures, largely for drugs that are in development. And diving into this, the key observation has been that people with type 2 diabetes tend to be at the highest risk of fibrosis and advanced fibrosis and cirrhosis. And as I like to say, this is a marriage gone sour in which each partner gets the worst out of the other one, because people with type 2 diabetes tend, as we mentioned, to have more of a risk of cirrhosis, more active steatohepatitis, and also people with type 2 diabetes have been found for now decades in epidemiological studies to have a higher risk of hepatocellular carcinoma. On the other hand, when we see in our clinic people with diabetes with NASH, they tend to have more dyslipidemia, more metabolic risk factors, and be more difficult to treat. In that context, I just wanted to share with you a typical patient, a 53-year-old man with diabetes. They have a number of comorbidities, and keep that in mind because that is one of the factors that limits and distracts the attention from Nafld of us as endocrinologists. We have to take care of a number of problems, as you see here: obesity, cardiovascular disease, this patient has chronic kidney disease, stage 3, hypertension, dyslipidemia, sleep apnea, and low testosterone levels. So we have to address all these issues in a follow-up that in the United States is scheduled every 20 minutes. In this person, also, there's a history of liver disease. That's something that should bring the attention to the clinician. And you see that also that the patient is obese, has an uncontrolled diabetes, elevated liver enzymes, and atherogenic dyslipidemia. In this complicated context, endocrinologists now are asked to find out if the person has fatty liver disease, but more importantly, if the patient has a risk of having clinically significant fibrosis, and when do they have to refer to the specialist. So let me go over this, and there's been progress, although changes in management and behavior by doctors are slow to happen. I mean, I think a key aspect was when in 2019, and now, of course, in the current 2020 standards, the recommendation was made that people with diabetes and elevated liver enzymes or a fatty liver on ultrasound that we can find from electronic medical records should be evaluated for NASH and fibrosis. This is a big step forward. However, it has been slow to embrace for a number of reasons. Among them, I think it also falls short because most of the patients that we have with fatty liver disease do not have elevated liver enzymes. So that is something to keep in mind, and why I think we should do systematic screening of our patients. This is a study that we did in 561 patients with type 2 diabetes and published in February of 2021. You see that about 1 out of 5 patients has fibrosis, some degree of fibrosis by elastography, but very few have elevated liver enzymes. And when we look a little bit closer, we see that about 15%, 1 out of 6, has what we would consider like F2 and F4. And we were able to biopsy about a third of the patients and confirming the findings. So again, liver fibrosis is not frequently associated with elevated liver enzymes above 40. Now, using lower cutoffs would be probably a solution, but still has not been embraced in a consensus. This is a very other interesting study we published in 2021, looking again, trying to separate diabetes from obesity in people without diabetes. And as you see in the overweight range, about half of the people with diabetes already have fatty liver using the USFLI. And if you go further into the obesity range, by the time that you have a BMI of 35, almost all people with diabetes have steatosis. And again, going up in people without diabetes and obesity as well. Now, the key thing is fibrosis. If you look at the traditional cutoff of 2.67 for FIB4, we see between 6 to 10% of individuals with diabetes have that higher cutoff, which would represent having F3 or F4. About half if you don't have diabetes. But if you take an intermediate cutoff of 1.67, that probably enriches it in F2 as well. It's 1 out of 5. So it's a high percentage of our patients with diabetes. The other aspect that we don't have a lot of time to discuss is that another big implication is that most people with Nafld, whether they have fibrosis or not, have higher risk of cardiovascular disease. And I think this is something that also is important because it helps us identify those people with diabetes with higher risk. So specifically, why still there's some lag in our attention as endocrinologists into this? One, there's unawareness. I still have some peers say, well, I've never saw somebody with ascites in my clinic. I think that happens because they just go from the hepatologist to the hospital for a decompensation and back to the hepatologist, and they skip the endocrinologist when they're very sick. Guidelines have not been placed yet to put enough emphasis. I think the ADA will change the guidelines to embrace more universal screening with FIB4. We have recently completed the American Association for Clinical Endocrinologists guideline, and with collaboration with ASLD, and hopefully this will have an impact. As I said, our patients with diabetes already have 5 or 6 medical problems to take care, and it is a bit overwhelming to add another problem, but that doesn't mean that we will not do it in the future. We don't have a great test yet for steatohepatitis or for fibrosis. FIB4 is okay, but has limitations that all of you are fully aware. And again, it's difficult for us as endocrinologists to shift from metabolic disorders to a liver disease. And we've not been very good at paying attention to liver enzymes unless they're very elevated. So I think changing that mindset to go first to a FIB4 test and later an elastography test or biomarker is going to take a little bit of time, but you know, we've done some work in this respect. So the key thing is for us to screen people for Nafld in the same way that we do it for diabetic nephropathy or retinopathy. This person, for example, has a FIB4 of 2.2, puts it in the gray zone. So this calls in, and we did an elastography test, confirming steatosis and level of stiffness that would be in the F1, F2 range. And that's why we, with Dr. Canwell, who's a leader in the American Gastroenterological Association, Dr. Shelbrook, who's a primary care doctor, a number of leaders in the liver and diabetes and obesity fields came up with these guidelines that will encourage doctors to order a FIB4, which allows them to at least half of the people with diabetes fall into the low risk. And then those who fall in the gray zone as our patient or high risk would eventually be evaluated with a second test. At the time of this, ELF was not approved in the United States. But I do think that elastography would be the best second test. But again, also assisted by other proprietary biomarkers like ELF that has a good outcome data, ProC3, which is now getting into a more broader and commercial platform, or NIS4 and others. And then this would help guide the management, divided into low risk, in which primarily the primary care, dietitian, endocrinologist, cardiologist, obesity management person would be involved with. The high risk on the other end, eventually with clear cutoffs and non-invasive tests, eventually with a liver biopsy, would be managed by the hepatologist and a multidisciplinary. And then those intermediate, indeterminate or intermediate or gray zone patients, many not willing to get a liver biopsy with intermediate values, again, also worked up and managed by a multidisciplinary team with a hepatologist. The key message here is that we do have, again, the need to consider weight loss if overweight or obese, cardiovascular risk reduction, keep the patient on a statin, and we have diabetes medications that work. Both are underutilized for different reasons. Pioglitazone has ample evidence in people with and without diabetes. I think this audience is already aware of that. So to finish, our patient had significant risk factors, a biopsy that confirmed NASH. We put the patient at semaglutide and pioglitazone and also a statin, very important. And the patient reached goals in terms of almost goals with A1C and frank reductions in liver enzymes. Take-home message is, I think, where we're going to be in 2022 is to incorporate the liver in the same way we do for renal and cardiovascular disease. And we have agents in the diabetes field that can work. The second step, I hope that the ADA in 2022 will incorporate NASH as another subgroup that should be managed differently. To end, I'm going to just finish with a few thoughts. Number one, I hope that the education that is going out for primary care and endocrinologists will lead to systematic screening of all patients with type 2 diabetes. because they have increased morbidity and mortality. Still, I have to admit there's significant inertia, but the calls to action from meetings like this, the job, excellent work that Dr. Lazarus and many of you in this international effort are helping to spearhead a change in our treatment paradigm. And the take-home message, there are things we can do today while we await the drugs that are under development to be approved by regulatory agencies: lifestyle, weight loss agents, metabolic surgery, and diabetes medications. Talking about screening for people with diabetes, screening is always important to be linked to an option for therapy. The cheap option would be pioglitazone, like the metformin for NASH. It's basically very inexpensive in the United States and most of the world. Semaglutide has shown the effects that I mentioned earlier. Other GLP-1 receptor agonists probably will be beneficial in the proportional to weight loss. And then SGLT2 inhibitors, although we don't have histological outcomes. So with that, we are waiting the new agents to become available. And I'll just stop here. Thank you very much. I'll introduce you to our group in Florida. Please come visit us soon when COVID allows. Thank you for your time.
Thank you very much, Dr. Cousy. And in keeping with having a multidisciplinary set of speakers, I'm very pleased to introduce Professor Shira Zellber-Sagi, a clinical dietitian, epidemiologist, and a researcher in nutritional epidemiology. Professor Zellber-Sagi is head of the School of Public Health at the University of Haifa in Israel, and she works as a clinical dietitian at the liver unit of the Tel Aviv Hospital. She's a member of the National Committee for Nutrition, Gastroenterology, and Liver Disease, and head of the Gastroenterology and Hepatology Nutrition Forum on behalf of the Israeli Nutrition Association. She will be speaking on healthy diets versus overweight obesity. Which are the barriers to healthy eating? Over to you.
Thank you very much for the invitation to give this talk today. When we want to think about the things that impact Nafld, we think about obesity and we think about dietary composition. And in fact, these two are connected together. We know that diet quality affects obesity, and obesity in turn affects metabolic status. But in fact, there is also a direct association between diet quality and metabolic risk. And the best example for this is the Mediterranean diet, which is good also for weight reduction and also good by its composition to treat Nafld. And indeed, the Mediterranean diet is the most established treatment for Nafld. In this meta-analysis, we can see that Mediterranean diet for 6 weeks to 6 months intervention leads to reduction in liver stiffness, fatty liver index, and HOMA insulin resistance. And if we want to look at longer term results of Mediterranean diet, we can look at this 18 months randomized clinical trial showing that Mediterranean diet leads to weight reduction better than just general healthy dietary guidelines. But more interestingly, in this study, 2 Mediterranean diets were compared. One was the usual Mediterranean diet and one was enriched with polyphenols. And interestingly, the Mediterranean diet enriched with polyphenols led to a greater reduction in the amount of liver fat. So that means that weight reduction is important, but there are other components in the diet and the dietary composition that have effect on the amount of liver fat. Interestingly, when they try to look which components in this diet best affected on the reduction of the amount of liver fat, they have shown that less consumption of red and processed meat are beneficial for reduction of liver fat, higher consumption of walnuts is beneficial, and higher consumption, not surprisingly, of polyphenols is beneficial for the reduction in the amount of liver fat. Indeed, this is supported also in a cross-sectional study by our group showing that higher consumption of polyphenols is related with reduced risk of Nafld, of significant fibrosis according to fibrosis markers, and reduction in the risk of insulin resistance, meaning that diet that is rich with polyphenols coming from tea, coffee, fruits, vegetables, and nuts can be helpful for Nafld regardless of obesity. This is also supported by this study showing that regardless of BMI, higher consumption of red and processed meat are related with increased risk of Nafld with or without cirrhosis. The polar opposite of Mediterranean diet is ultra-processed food rich diet. Ultra-processed food is the highest source of sugar and sugar beverages and saturated fat and unhealthy nutritional compounds in a Western diet. We have shown that the greater the consumption of ultra-processed food in the diet, the greater is the risk of having metabolic syndrome. And more interestingly, among smokers, those who had a higher consumption of ultra-processed food had a greater risk, twofold increased risk of having significant fibrosis. So the combination of two risk factors, smoking and unhealthy diet, are related with increased risk for fibrosis. So not surprisingly that the recent EASL-NAFLD patient guidelines recommend consumption of Mediterranean diet, healthy dietary components, and to minimize the consumption of ultra-processed foods and beverages rich in saturated fat and sugar. And of course, physical activity is always recommended. But what does it take to have a successful dietary intervention? What do we really need more than just knowing what foods we need to eat? So first of all, we need physicians to recommend a healthy diet. And although physicians perceive nutrition counseling as a priority, they lack the confidence and knowledge to effectively provide the advice for the patients. In fact, in one of the surveys, fewer than 1/3 of the physicians were confident in their ability to assess or advise on nutritional status. And that means that we need to have more training, nutritional training for the physicians. Also, it emphasizes the importance of a multidisciplinary team, including clinical dietitian, to have a comprehensive nutritional counseling. And indeed, there is a suboptimal dietary treatment of Nafld patients in the usual clinical practice. This is an example from the United States on about 2,000 Nafld patients. Only 3% of them actually get to see a clinical dietitian. Only half of them were recommended to have diet, and fewer, only 15% were recommended to perform exercise. Only 1/3 achieved weight reduction, and many of them had weight gain during follow-up. So we definitely need to improve nutritional treatment in clinical practice. And sometimes nutritional treatment is unavailable for the patients. It is sometimes not covered by their health insurance, for example. And that brings us to the topic of web-based programs. So I'll give you two good examples for web-based programs. One is an exercise web-based program, which was conducted for a couple of weeks, 8 weeks of intervention, and then 12 weeks of web-based program. And that intervention, in fact, led to steatosis and fibrosis reduction according to scores, and to reduction in liver stiffness. Another example is lifestyle intervention program of 24 months, a long-term intervention, which was web-based. And in this intervention, the web-based program was compared to usual intervention of group-based intervention. And what we can see is that weight reduction and improvement in liver measures were similar among the two interventions, the group-based intervention versus the web-based intervention. So web-based can be one optional solution for the patients who do not have nutritional counseling available. What does it take to have a successful lifestyle modification? So in the Look Ahead study, in the follow-up of 4 years, we can see that intensive lifestyle intervention led to greater weight reduction in the long term as compared to just nutritional education. Furthermore, the more treatment contacts people were having during these years, the less they gain weight and the more they lose weight. And if they exercise more, again, the less they gained weight and the more they lost weight. So the The constant contacts are important, and physical activity are important for long-term weight reduction and maintenance. And this is an excellent summary of 51 high-quality randomized clinical trials pointing at the prominent components of a successful lifestyle intervention, including 3 factors: behavioral strategies to facilitate adherence, comprehensive dietary advice, and of course, physical activity. And we need to remember that nutritional treatment is a lifelong challenge, and so those people need to be treated for lifelong lifelong interventions. It's something that they need to do for the rest of their life to reduce weight and keep the weight down. And physical activity is a crucial, not only for weight reduction, it is crucial also for weight loss maintenance. And this is a conceptual model of patient-related factors and lifestyle behaviors in Nafld. This is a summary of 3 studies showing that if patients have poor understanding of what Nafld is and its relation to diet, they will not keep up with the diet. But if we explain to them the importance of Nafld, and most importantly, that this is a diet that can have a regression or at least reduce progression by lifestyle modification, and that it actually works, they will have a greater motivation to start and maintain lifestyle modification. So we need to provide them the knowledge and provide them the motivation to have a lifestyle modification and to keep it. And we also need to remember that the environment is a toxic environment or obesogenic environment because we are surrounded with temptations. There is a lot of challenge to keep a healthy diet in a toxic environment. And furthermore, we are exposed to digital marketing, very, very aggressive digital marketing, targeting especially children and adolescents. And actually, it has been demonstrated that children and adolescents are very much influenced by this digital marketing of unhealthy foods and drink. And therefore, the very recently published is a Lancet Commission published on December 2021 actually calls for a complete ban on marketing of unhealthy foods towards children in all social and digital media. And I think this is really important to change the environment and to make the healthy choices the easier choices. And with that, I really thank you for listening.
Thank you, Professor Zilber-Sagi, for this wonderful summary on a very important topic in Nafld management. For the last talk of this first session, we will switch to another very important perspective, that of a Nafld patient. And it is my pleasure to introduce Robert Mitchell Thane, who speaks to us from his role as a Nafld patient who has been thoroughly involved in several initiatives. He is the Director of Pediatric and Rare Liver Disease and Director of Patient Insights at the Global Liver Institute. He is the Vice Chair of Liver Patients International and is a fierce patient advocate as a Nafld patient himself. He has been involved in numerous collaborative committees, led and co-authored a number of patient-centric abstracts, and is the co-author and reviewer of clinical guidelines and journal articles. He will speak to us today about his Nafld journey from his perspective. You have the floor.
Okay, hello. Thank you very much for joining me. Thank you very much for the organizers and for the chair for allowing me the privilege of speaking to you today. I'm going to talk to you about Nafld, the patient perspective. Before I do, I'm going to ask you very, very quickly, would you mind just at your desk, if you're watching this presentation, can you just quickly jot down your name for me, please? Just very, very quickly. So on the subject of names, my name is Robert Mitchell Thane. I'm Director of Patient Insights at the Global Liver Institute. I'm also the Director of Pediatric and Rare Liver Diseases at the Global Liver Institute. I'm also the Vice Chair of Liver Patients International, and I am a fatty liver disease patient. Now that you've written your name down, I'm going to ask you to do it again, but would you mind just doing it with your other hand? So put your pen in the other hand and just quickly jot down your name for me, please, if you could. I'd be grateful. Thank you. So when we talk about the patient perspective, the patient journey, there isn't one patient, there isn't one patient perspective, there isn't one patient journey. However, there are commonly discussed hurdles. We know the levels of awareness are not ideal. We know that screening is not ideal. We know there's no consensus on screening, which is not ideal. We know there's no clear clinical pathway. There are no current treatments available, which is not ideal. And then we have what we term the psychosocial issues. And this is the part that I really, really want to focus on. Now, just while I was talking about that, hopefully you will have jotted down your name again, but using your other hand. And I imagine if I were to ask you, how did that feel? Probably less comfortable, maybe challenging, maybe difficult, maybe awkward, maybe fun. I don't know. But what I asked you to do was to experience change. Okay, something as simple as writing your name. By changing one aspect of that, we have made it immeasurably more difficult than how we do on a daily basis. So I want to raise that with you, and I just want that to be in the background as we talk. So I'm going to go to the character now, Andy Capp. Now, Andy Capp is a comic character, and he goes to the doctor. He says, "Doctor, what is the best thing I can do to improve my health?" And the doctor says, wise words, "The best thing you can do is give up smoking, drinking, and fried food," all of which is common sense, all of which is sound medical advice. Yet Andy Capp's response is, well, actually, what's the second best thing I can do? And the reason I raise this is not to be disparaging or to speak in any kind of detrimental way about patients, but to highlight the patient journey. Because when we hear words like, oh, you could do with losing a few pounds, or you just need to get some exercise, all of those kind of things elicit what we call an emotional hijack. So when you look at this picture of the brain, okay, you've got what we'd call the cognitive part of the brain up the top, and then just underneath in the purple and in that kind of brown walnut area is what we have is our emotional brain. So when the doctor says to us, you need to lose a few pounds, or you need to exercise more, or any of those things, we don't think up here in our logical part of the brain, we don't think, oh, that's sound medical advice, I think I'll go and do that. No, we hear that, we perceive that as a threat. And so we hear that right back here in our emotional part of the brain. And that leads us to have an emotional hijack, which means you get an emotional response, which means we're not thinking creatively to produce a win-win or to create solutions or any of those kind of things. We just have this emotional, intense fight, flight, freeze response. So that brings us to our everyday reality of living with fatty liver disease, NASH, call it what you will. So the first thing is the visceral gut reaction. And so there's guilt. I've done this to myself. I should have known better. I should have done better. I should have made better choices. And we carry this each and every day. We carry this as individuals. We carry this as family members, as friends, as caregivers, as work colleagues. We carry that guilt. Now, I've deliberately put these in a random order because what we go through isn't logical. It's not smooth. It's a whole series of events that all happen in a random manner. So the next one I want to talk about is managing change. Now, just a few moments earlier, I asked you to write your name in a way that was completely different to what you were used to. What's the norm? And you probably would have found that slightly uncomfortable. Now, I know there's lots of clinicians in the audience, and we won't even ask them to look at the two forms of the handwriting to see which is better, because frankly, they might be the same. But what I'm saying is that actually doing something different was more challenging, more difficult. Yet we're asking patients to go and manage change. Now, when you talk to the fellowships, Alcoholics Anonymous, Gamblers Anonymous, Narcotics Anonymous, they will tell you that roundabout, so AA, for example, will tell you that around about 2 to 3% of alcoholics make it into a meeting. Of that 2 to 3%, round about 2 to 3% come back again on a regular basis. And then once they're actually attending the meetings, it's those who are following a program, not necessarily the program, but a program, who are the ones that have the most success. Now, when you are following a program, your chances of success are enormous. But when you're not, you're a kite in the wind. And so this is one of the things I want to highlight about the patient experience, is that they are a kite in the wind. And yet we're somehow to manage change. And when you look at, abstinence programs or weight loss programs, there's a huge amount of support that is available there, but we're asking patients, telling patients they need to make these lifestyle changes, but there's no support mechanism to allow them to do that. Now, we can talk about nutrition security, not just food security, proper nutrition security. So we need to look at, inequality. We need to look at equity of access. We need to look at the societal norms. We need to look at paying an honest day's pay for an honest day's work. We need to look at all of these things because these all have an impact on patients and on their Nafld, on their chances of getting Nafld, and on their chances of actually dealing with it and helping themselves. Okay, and the next thing I want to talk about is our family. Okay, do we live with enablers? Do we have people who kind-heartedly think, you know what, you've done really well this week, so I've got you a wee dessert for after your dinner tonight? Which is a lovely thing to do, but is it helpful in terms of people making change? If I change my diet, if I'm going to eat more healthy, if I'm going to exercise more, do I do it with my family? Do I take my family with me on that journey? Do my family volunteer to come with me on that journey? Or are we lost? Are we talking about sugar addiction? There's data out there that says that pound for pound, sugar is more addictive than cocaine. Yet we're not dealing with this. We're not talking about this. And we're not addressing this as one of the aspects of living with non-alcoholic fatty liver disease. Sugar has an impact, as does advertising. When you look at, adverts, and you go to the cinema and there's the adverts for the popcorn and for the fizzy drinks and for everything else. You're watching a film at home on the TV and there's the advert that is designed by psychologists to trigger your most primal responses. And you, as an individual patient, what chance have you got of actually being able to fight that day after day after day after day? And then there's things like shift work. There's things like dietary advice. There's things like shopping. Go to a petrol station. Stand in the queue for the petrol station, and what do you see eyeline? Chocolate bars. Over and over again. Or the donuts, which happen to be cheaper than apples are. And on it goes and on it goes. One of the key things, now it's linked to nutritional security, but actually it's one of the things that we face as a patient population. Privilege. Now I'm in a privileged situation. I'm male, middle-aged and white. So let's leave that to the side. I'm reasonably intelligent, some would say, not everybody. I'm reasonably good at communication. Some would say, not everybody. And I have all these things that are able to help me in my journey and my struggle. And yet even I find it difficult to lose weight and to make an impact on my life, my quality of life, and on my Nafld. So what chance are people who are not in that same position? Again, what chance have they got? And then I'll just throw it in there, setting a good example. Those of you that are in a clinical setting, when you look at your words, when you look at your language to patients, but also when you look at your vending machine, what is in the vending machine? I bet it's not healthy. So I want to talk to you about words matter, because I want to talk about patient advocacy groups. I want to talk about patient support groups. So when Andy Cap comes back and says, what's the second best thing you can do? The second best thing you can do is join a patient support organization. We see each other, we can mentor each other, we can support each other, we understand. And I always say to patients, if you think you're too small to make a difference, then try sleeping with a mosquito in the room. Again, you have my thanks, you have my appreciation. I'm Robert Mitchell Thane, rmitchellthane at globalliver.org. Thank you.
Thank you, Robert. It was very enlightening, always very interesting to hear the patient's perspective in this disease as clinicians. I'd like to thank all the speakers for the wonderful perspectives that highlight how much we know, but also the many opportunities we can leverage for the multidisciplinary care of these patients. We have several questions trickling in through the chat, so please continue to participate. We look forward to your interaction with questions. I will maybe start with one for Professor Frank, and maybe Robert can weigh in as well. The question relates the involvement of patients in developing guidelines. And there's a question asking about the experience of this process. Professor Frank, I think you are, we can't hear you. You are on mute. Maybe we can start with Robert's perspective until we fix the technical difficulties.
Okay, perfect. Thank you, and happy to give way when the professor's microphone comes back into operation. So it was interesting to see the PBC Foundation lay guideline there. It was the first one that certainly that we were aware of. I was actually involved in the PBC Foundation. I was one of the lay authors. And as was highlighted in the presentation, it was really important at that time to set a precedent and to take the information that was available to clinicians, look at best practice of care, and then somehow translate that for patient view. But I think it's been a wonderful progression to actually see that A, patients are being involved, but B, they have their own specific guideline now. So instead of taking a translation of this is what the doctors need to know, use that to try and empower yourself to actually look at patients in the eye and say, here's the information that we think you need. And then when we say we, that includes the patient population and community involved in writing that. And I think it's an amazing step forward. And the feedback on the street, if you will, amongst the patient community is that this is incredibly important and also very empowering.
Thank you. Professor Frank, do we have you back?
I don't know. Do you hear me now?
Yes, we can.
Okay. Happy that the problem is solved. No, what our experience was a little bit what the cartoon of Robert also illustrates. We started, and Robert alluded to it just a minute ago, from the idea of having a kind of lay translation of the scientific guideline, but in the process that we followed, it was clear from the beginning that was not what the patients needed, and what was very fruitful in having the patients from the beginning in the journey was that they could tell us what their expectations were, what their needs were, and that defined finally the content of the guidelines. So it was in that respect a very nice, but also for me a lesson learned that from a physician's perspective you have the technical knowledge and you look from it from a specific side, but then you have to meet the expectations and the needs of the patients, which can be completely different. So it was a very how should I call it, I learned a lot with that the experience. It was a very nice experience, and we ended up with a completely different document than what the initial idea was.
Thank you.
Dr. Cousy, a number of questions have come up from the participants. I'm combining a couple of them that I see written into our chat. One participant says, well, the relationship between NAFLD and diabetes is so well established, and you were focusing on the importance of endocrinologists diagnosing and addressing NAFLD. For NAFLD patients, should they be assessed for diabetes or pre-diabetes, and where, when, and how?
Yeah, given that there are lots of questions and a lot of attendance, so I'm going to do short answers, okay? And we can expand. So yes, that's a very, very good concept, particularly because the severity of NASH and the risk of cardiovascular disease, of NASH with advanced fibrosis, and cirrhosis is pretty much the same. And the risk of cardiovascular disease are rated 2 or 3-fold. So yes. However, the emphasis that I put on diabetes is, well, number one was the topic, and number two, because a very clear, defined, unquestionable group from which I hope once we develop the habit of screening those, it will trickle down to the bigger base, right? There's at least 2 or 3 or 4 people with pre-diabetes per each one with diabetes. So I agree 100%. And the treatments work equally well in people with pre-diabetes. So great thought.
Great. Well, thank you very much for your insight on that. And while I have the floor, question directed to Dr. Shira. Why do you think, or could you explain if seeing a clinical dietitian in person would give the same kind of results as the various online programs? So we know there's a lot of discussions around digital health. Here we are not meeting in person, but what's the literature telling us about in-person consultations versus online programs or some sort of combination of them?
Well, thank you. I'm very happy for this question because generally I think that there is nothing like the personal contact with the patients. We create a personal connection and we speak not only with words, there is the body language, and we have a very close relation with the patients. We follow patients with diet for years. Actually, I have patients knowing me for 20 years, for example. They know the names of my children, and there's nothing like the personal contact. Also in the study I presented on lifestyle intervention, actually there was a huge attrition rate in the web-based intervention. So it was very effective, but it was effective only to some of the patients who actually continued with the program. Others did not continue. So that means that web-based interventions are good only for certain patients. And I think in the future, obviously we will have to combine the personal intervention with the web-based interventions. I don't think any one of them can stand alone, because we need a personal contact on the one hand, and on the other hand, we need to make the dietary intervention available to everyone. So that will come with the web-based interventions. Thank you.
Yeah, I think there's going to be a lot more discussions on how to handle digital health and digital health interventions the way the world is going, but hopefully we're going to be seeing an end soon to the COVID-19 pandemic. I'm sure another question came in, so let me just ask you before I hand back to my co-chair about new labeling stickers on high sugar, high fat foods. The participant says, they appear remarkably smart, but do you feel this helps patients and young adults make better choices? Is there any published evidence on this?
Well, yes, there is evidence showing that it helps to make more smart food choices. There are also studies from Israel. Israel has very new food labeling in the past 2 years, and evidence shows that it's effective. But we need to remember that it cannot be the only intervention. It provides knowledge, it provides another tool to help the patients, but it cannot stand alone. And we need also to have education, we need to have dietary support, we need to change the environment. Eventually, one of the goals of food labeling is to encourage the food industry to do food reformulations. So if they don't want to get the red label, they need to change the composition of the unhealthy foods. So actually in the Israel Lancet Commission paper published recently, OECD modeling has shown that food labeling and food reformulation has the greatest potential to improve health, to improve nutritional intake, and to save health costs. So I think this model just strengthens what we know, that these are two effective methods. But again, it has to come with a lot of other changes and support for the population and especially for Nafld patients.
Thank you very much. Yeah, it makes sense that food reformulation will be an important contribution. I guess we'll see what happens with labeling. I'm not sure companies will be so worried about the red label if everyone continues to buy it. So it will be up to the consumer to think through what they're putting into their bodies.
Great. I think we have several questions, all really interesting. I will choose the next one for Robert, and it's a very important one, which relates to that sustainable aspect of weight loss. And the question is, have you as a patient ever broached with a clinician the putative benefits of interventional surgery for weight management? Did you find patients in UK, as an example, are finding this being presented given restrictions around funding decisions for this in the UK?
No,
And I would just add that in the US is a very expensive procedure as well, so it's applicable worldwide.
No, absolutely. It's a great question. So thank you for the question. First off, personally, no. I'm a patient advocate working for a charity, so it's probably somewhat beyond my budget to go and do that kind of thing privately. And yeah, you know, as we know, the 2022 is not the easiest year for medical funding in any country in the world. So, you know, this is not sitting high on the priority list. So I don't think that's a realistic approach for most patients. But I think one of the key things is to come back to, you know, what Dr. Shearer said earlier, that actually there is no one answer. So, you know, the online support would work for some patients. Face-to-face support is going to work for some patients. And I think, you know, the interventional surgery could potentially work for some patients, but there still needs to be a degree of support and education that goes with that. But in terms of the financial aspects, I do think that it's not realistic to be able to expect that for most patients.
Thank you.
Ken, as we move into the last few minutes before we take a short break, I'm wondering, you know, in the near term, what can we do to get more endocrinologists on board to be testing for Nafld?
Yeah, so that's a great question. So number one, I think it's going to really turn around when really endocrinologists, you know, become familiar with simple practices and they begin seeing people with NASH in their clinic and feeling that they're doing a difference. I think the challenge is getting to that point for the reason that I explained before. Time. There's no economic incentive, and there's a lot of other pressures. I think that the first big step could be putting it on the spotlight by putting them on guidelines. So I'm very excited that, for example, we are going to come out in the next weeks with the American Association of Clinical Endocrinology guidelines tailored to endocrinologists. And ADA is also going to be more active this year, and all societies are stepping up. So I think when we bring it to the next level of attention, I think that would be the big first step. And when we have, you know, a simplified FIB4 with another test, I think that is also going to help. But again, as we've learned from other guidelines, cholesterol guidelines, blood pressure guidelines, it takes time to change behavior. So I'm hopeful that there's a significant momentum building up, at least in our field.
Great, thank you very much. And thank you to everyone participating in this session. I really enjoyed the presentations, the discussions. We heard from an endocrinologist, from a dietitian, clinical nutritionist, from a hepatologist, from a patient advocate. Thank you to my co-chair. We're going to take a brief 5-minute break now. The timing is fantastic because it looks like all of the electronics and setup has worked on my side, except that as the sun goes down, I need to get up and turn on the lights, or I'm going to be sitting in the dark for a few minutes. So we're going to take 5 minutes and then we'll come back for session 2. Thank you all again.